Hello everyone. Hello students. Today's topic of discussion is important clinical cases. Today we will discuss about the important cases from the topic enzyme and all three metabolism, that is carbohydrate, lipid and protein metabolism. Also we will discuss the important cases from the hemoglobin metabolism and nucleotide metabolism. So total we will discussing near about the 50 clinical cases and key points for the diagnosis of these cases. Only the key points we will be discussing here. Okay. Now from the topic enzyme, these are the four important cases, that is myocardial infarction, viral hepatitis, obstructive jaundice and pancreatitis. कौन कौन सी बोली मैंने? Myocardial infarction, viral hepatitis, obstructive jaundice and pancreatitis. Now how will you diagnose a case of myocardial infarction? So you will get a case history of chest pain. Chest pain is the prominent feature in the myocardial infarction. What is myocardial infarction? It is decreased supply to the part of the heart that causes the symptom, and that also causes the ECG changes. So these are the two important symptoms related with the myocardial infarction, and these are the cardiac markers. CKMB is the earliest enzymatic cardiac marker, while troponins, troponin I and troponin T, these are the specific proteins that their levels are elevated in the myocardial infarction. Okay, there is difference in the myocardial infarction and cardiac failure. Okay, heart attack, जो भी हम heart attack बोलते हैं generally, that is myocardial infarction, means decreased blood supply to the certain parts of the heart, and heart failure means inability of heart to pump the blood. So these are the two terminologies related with this. So this is a important case, myocardial infarction and cardiac markers. Now viral hepatitis. Viral hepatitis, you will get flu-like symptoms, fever and flu-like symptoms with elevated SGOT, SGPT levels. Specifically the SGPT levels are raised, or SGPT levels are elevated. Okay, so raised SGPT, SGOT level along with slight increase in the alkaline phosphatase activity, and the bilirubin, both type of bilirubin, direct and indirect bilirubin, both are elevated. That is known as biphasic Vandenberg reaction. That is known as biphasic Vandenberg reaction. जब भी आपको ये वर्ड अगर दिखता है biphasic Vandenberg reaction, Vandenberg reaction is nothing but the principle of bilirubin estimation, that is formation of azobilirubin. Okay, so whenever there is biphasic means direct positive and indirect positive, it indicates the hepatocellular jaundice, means mainly the viral hepatitis. This is the second case. Third is a obstructive jaundice. In the obstructive jaundice, obstructive enzymes are raised. For example, alkaline phosphatase, 5' nucleotidase, gamma glutamyl transferase activity. These are the obstructive enzymes. Their levels are raised along with the increased direct bilirubin, and SGOT, SGPT level, it is near about normal to slight increase in the SGOT, SGPT level, and no urobilinogen in urine. These are the diagnostic point for the obstructive jaundice. Along with the case history that will suggest you the pain in abdomen, pruritus, itching all over the body, pain in the abdomen. There is raised cholesterol level in this obstructive jaundice. Apart from this symptoms are these laboratory parameters. Okay, this is obstructive jaundice. Major is to differentiate between these two, viral hepatitis and obstructive jaundice. इसमें जो है SGOT, लीवर ट्रांसअमाइनेज जो है वो बड़े हुए रहेंगे, इसमें अल्कलाइन फॉस्फेटेज बड़ा हुआ रहेगा. इसमें सिम्टम्स क्या रहेंगे? पेन रिलेटेड सिम्टम रहेंगे, क्योंकि जब भी बाइल के फ्लो को ऑब्स्ट्रक्शन होता है, दैट कॉजेज द ऑब्स्ट्रक्टिव जॉन्डिस, particularly the stone in the common bile duct, also the carcinoma of head of pancreas which obstructing the bile flow. So these are the causes, so that causes the pain in abdomen. Here the non-specific symptoms are there and flu-like symptoms are there in the viral hepatitis. Now next is the pancreatitis. Again manifestation is pain in the abdomen, and there is increase in the serum amylase and serum lipase level. Serum lipase is more specific for pancreatitis. There is also a history of alcoholic. So chronic alcoholic are more infected or more prone to the pancreatitis, and typically this abdominal pain is relieved by the uh, that is known as Mohammedan prayer sign. When you lean forward, the pain is relieved. That is the typical pain of pancreatitis. So these are the four important disorders related with the enzyme topic: myocardial infarction, viral hepatitis, obstructive jaundice, and pancreatitis. Here lipase is more specific than amylase for diagnosis of pancreatitis. Got it? These are the four disorders. Now moving to the next, that is carbohydrates, carbohydrate chemistry and metabolism. In the carbohydrate chemistry, two important disorders are there: Hurler and Hunter syndrome, that belongs to the mucopolysaccharidosis. Hurler and Hunter syndrome. In this Hurler and Hunter syndrome, there is elevated level of glycosaminoglycan, particularly the heparan sulfate and dermatan sulfate. Level of these two increases. And whenever there is heparan sulfate in any mucopolysaccharidosis, whenever there is increase in the heparan sulfate, it causes mental retardation. It causes neurological manifestation. In mucopolysaccharidosis, there is multi-system involvement. The coarse facial faces, these are the typical manifestation, that is coarse faces, then short stature, hepatosplenomegaly, okay, short neck, corneal clouding, skeletal abnormalities, and urine, there is excretion of heparan sulfate and dermatan sulfate in the urine. It is due to the deficiency of enzyme iduronidase. Iduronidase. There is accumulation of heparan sulfate and dermatan sulfate. Iduronidase, it is involved in the degradation of heparan and dermatan sulfate. As there is defect in the iduronidase, there is accumulation of these two glycosaminoglycans, and these are the different features. Now, how to differentiate between Hurler and Hunter? Hunter typically affect the males. Remember, Hunter typically affects the male, and Hunter has clear vision. There is no corneal clouding in the Hunter syndrome. It is a X-linked disorder, that's why it affects the male, and all other features are similar as that of the Hurler syndrome. There is multi-system involvement. Okay, Hunter syndrome. So these are the saccharidosis. Apart from these two, there are many mucopolysaccharidosis. For example, the Sanfilippo ABCD, Morquio disease, Morodex Lamy, these are the different mucopolysaccharidosis. Of these two are common. Okay. Now the moving to the metabolism of carbohydrate in the intolerance, the lactose, sucrose, and hereditary fructose intolerance. These are the three intolerance related with the carbohydrate metabolism. Okay. When there is symptoms like loose stool after a breastfeed, which contain lactose, okay, means lactose agar diya to it causes the symptom in the form of loose stool, excessive cry, irritable child, abdominal pain, cramps, and flatulence because of deficiency of enzyme lactase. Which enzyme is deficient? Lactase. So there is no degradation of lactose, and that causes fermentation, and these symptoms are there. And if you shift the child on the lactose free commercial preparation, अगर artificial lactose free preparation उसको दिया तो उसके symptoms relieve हो जाते. That is lactose intolerance. Lactose free diet is given. Okay, so this is lactose intolerance. Similar symptoms: abdominal pain, cramps, diarrhea, flatulence after the sucrose rich diet, which is particularly present in the fruit, sugarcane. अगर ये डाइट दिया तो उसको सिम्टम्स ये एग्रीवेट हो जाते हैं. दैट इज सुक्रोज इंटॉलरेंस. इट इज पर्टिकुलरली इन द एडल्ट, सुक्रोज इंटॉलरेंस. एंड सेम सिम्टम्स is there in the hereditary fructose intolerance when we take the fructose rich diet, but additional it is more severe as compared to the sucrose intolerance. In the hereditary fructose intolerance, it is due to the deficiency of enzyme aldolase B defect, which causes the conversion of fructose 1 phosphate into DHA, that is dihydroxyacetone and glyceraldehyde 3 phosphate. So there is accumulation of fructose 1 phosphate, which causes jaundice, which causes hepatomegaly, which causes fasting hypoglycemia. So this is somewhat more severe as compared to this. This is due to the deficiency of enzyme aldolase B, hereditary fructose intolerance, aldolase B defect. When we take the fructose rich diet continuously, there is hypoglycemia, hepatomegaly, and the jaundice like features in hereditary fructose intolerance. So these are the disorders, that is Hurler syndrome, Hunter, lactose intolerance, sucrose intolerance, and hereditary fructose intolerance. Moving to the next. See. Now the glycogen storage disorders, which are very, very important in the carbohydrate metabolism, specifically the von Goer's disease. There is fasting hypoglycemia in the von Goer's disease. This is a liver glycogen storage disorder. Liver glycogen storage disorder in which hepatorenal is there. There is involvement of the liver and involvement of the kidneys. So hepatorenal is there. There is no spleen involvement and there is no muscle involvement in this disease. Von Goer's disease, it is due to the deficiency of enzyme glucose 6 phosphatase. It is due to the defect in enzyme glucose 6 phosphatase, and this enzyme is absent in the muscle. That's why muscles are not involved in the von Goer's disease. Apart from this hepatorenal and fatty cheeks that gives the doll-like faces, these are the laboratory parameters which are helpful in the diagnosis of von Goer's disease. Hypoglycemia, there is decrease in the plasma glucose level. There is hyperuricemia, uric acid levels are raised because this glucose 6 phosphatase defect diverts the glucose 6 phosphate to the HMP shunt that increases the ribose, which is a important precursor molecule or the starting substrate for the synthesis of the uric acid. So uric acid levels are raised. There is increase in the lactic acid level. Also hyperlipidemia is there because glucose 6 phosphate is diverted for the acetyl coenzyme synthesis, which is utilized for the fatty acid synthesis. That's why there is increase in the lipid levels also. So there is no spleen involvement, no muscle involvement in the von Goer's disease. This is hepatic glycogen storage disorders. Biopsy, liver biopsy is the diagnostic test for the glycogen storage disorders. The liver cells are laden with the uh, glycogen. Okay. The Pompe's disease, this is muscle glycogen storage disorder in which muscle is involved. Also main is the heart, involvement of the heart and cardiomyopathy. Because of involvement of heart and heart failure, death at early age occurs. Near about 18 months to 2 years of age, the death occurs, death of the child occurs. There is cardiomegaly, there is involvement of the muscle which causes hypotonia and floppy infant, and the tongue involvement, tongue hypertrophy is there in the Pompe's disease. This is due to the defect in the enzyme lysosomal acid maltase. Lysosomal acid maltase. Okay. Then McArdle's disease, it is due to the defect in the enzyme muscle glycogen phosphorylase. It is due to the defect in muscle glycogen phosphorylase enzyme. And the typical feature is exercise intolerance. If the patient take pause for some time, he can resume his activity with little discomfort. That is known as second wind phenomenon. मतलब थोड़ी देर के लिए अगर वो रुक गया और उसके बाद उसने अपनी एक्टिविटी रिज्यूम की तो वो अपनी एक्टिविटी थोड़ा सा इससे कर सकता है. दैट इज सेकंड विंड phenomenon. Exercise intolerance, early fatigue. This is muscle glycogen storage disorder, and there is, if prolonged if activity is continued, then it causes myoglobin urea and passage of brown or burgundy color urine is there due to rhabdomyolysis. So McArdle's disease due to defect in muscle glycogen phosphorylase. Cory's disease and Anderson's disease. Cory's disease, it is due to the defect in debranching enzyme CD and AB. Anderson disease, it is due to defect in the branching enzyme. In this disorder, there is liver involvement and progressive liver cirrhosis, and there is increase in the SGOT and SGPT level in Cory's and Anderson's disease. In this disorder, there is particularly involvement of the liver, but muscles are also involved in the type 3 and type 4 glycogen storage disorder. So these are the important glycogen storage disorder which can be asked in the examination, particularly these three: von Goer's, Pompe's and McArdle's. Now the G6PD deficiency, this disease is related with the HMP shunt, that is hexose monophosphate shunt. And hexose monophosphate shunt, it is important for generation of NADPH, particularly the NADPH, which is related with the glutathione reductase activity and maintaining the RBC membrane. So it prevents the hemolysis. So G6PD deficiency, it is related with HMP shunt. Now when it is normal, as such patient lives normal, but when it is exposed to the oxidant drug, for example, particularly the anti-malarial drug primaquine, if primaquine is given or sulfonamide or acetanilide is given, these are the oxidant drugs. This causes the generation of reactive oxygen species, as there is decreased activity of G6PD, glucose 6 phosphate dehydrogenase. Due to deficiency of this, NADPH production is low, glutathione reductase activity is low, and as there is, due to this oxidant drug, there is production of reactive oxygen species. It causes the RBC hemolysis and jaundice is there. Unconjugated bilirubin levels are raised in the G6PD deficiency. Okay. The next one is the galactosemia. Remember the congenital cataract due to accumulation of dulcitol in the lens. Due to accumulation of dulcitol or galactitol in the lens and osmotic effect of dulcitol or galactitol causes the cataract, that is congenital cataract. Then fasting hypoglycemia is there, hepatomegaly is there, jaundice is there, mental retardation is there, because this is because of this galactosemia is due to the galactose 1 phosphate uridyl transferase defect, the classical galactosemia. Other galactosemias are also there, that is galactokinase defect or galactose epimerase defect. These are also there, but this is classical galactosemia in which galactose 1 phosphate uridyl transferase is defective. It is characterized by congenital cataract and galactosemia. Due to defect in this enzyme, galactose 1 phosphate accumulates, and this causes the accumulation in the various tissues, particularly in the liver, that affect the bilirubin conjugation, and that causes the hepatomegaly. So hepatomegaly is there, jaundice is there, and mental retardation is there in the galactosemia. The dulcitol accumulation or galactitol accumulation causes the congenital cataract due to osmotic effect. So this is galactosemia. Now what is diabetes mellitus? It is very easy: polyuria, polyphagia and polydipsia. Increased frequency of urination, that is known as polyuria. Polyphagia means eating, more eating, and the polydipsia means more drinking of water. Why these symptoms are there? Polyuria is there because the blood level of glucose crosses the renal threshold, that is 180 milligram per deciliter. 180 milligram per deciliter के ऊपर अगर sugar level गई तो it is renal threshold, it crosses the filtration barrier and it comes into the urine. Polyphagia is there because decreased uptake in the insulin insufficiency or insulin deficiency. There is decreased uptake of glucose by the cell, and the cell starved for the glucose. As the because of these, hunger centers are stimulated, and that causes polyphagia. And polydipsia because of increased urination. There is loss of water in the urine that causes the stimulation of the thirst center, and polydipsia is there. There is increased plasma glucose. This laboratory investigation shows the increase in the plasma glucose level. That is fasting plasma glucose, that is more than 110 milligram per deciliter, and post meal plasma glucose. So for the diagnosis, it is more than 140 milligram per deciliter. So this indicates the impaired glucose tolerance. When the fasting is more than 126 and the post meal is more than 200, that indicates the diagnosis of diabetes mellitus. And the glycated hemoglobin more than 6.5%. So when the fasting plasma glucose is more than 126, post meal plasma glucose is more than 200, and glycosylated hemoglobin HbA1c is more than 6.7%, it indicates diabetes mellitus. Okay. So you may get a case of diabetic ketoacidosis. Most probably this is a simple case. So they will not ask, the examiner will not ask this, but he will definitely go with the diabetic ketoacidosis. Patient come to the hospital or emergency department in the conscious or semi-conscious state. This conscious or semi-conscious state, it is because of the metabolic acidosis and dehydration. Metabolic acidosis and dehydration causes the unconsciousness in the patient. Okay, rapid breathing is there, that is known as Kussmaul respiration, deep and rapid breathing. This is a compensatory mechanism. As there is metabolic acidosis, it is compensated by the hyperventilation, by excreting or exhalation of the CO2, hyperventilation. This is a compensatory mechanism. Kussmaul breathing is there. Fruity order of breath and fruity order of the urine is there because of excretion of ketone bodies in the urine. Then there is elevated plasma glucose level. Benedict test and Rothra's test both are positive. And there is hyperkalemia. This is a compensatory mechanism because hydrogen ion concentration in the blood is much more, and to compensate that, hydrogen will move inside the cell, and in exchange the potassium will move outside. So hyperkalemia is there. So you may get a case of diabetic ketoacidosis. Okay, this is very important case for first year MBBS students. So these are the cases, that is G6PD deficiency, there is hemolysis, increase in the unconjugated bilirubin, it is related with the HMP shunt. Galactosemia, it is related with the galactose metabolism, galactose 1 phosphate uridyl transferase defect, and there is cataract. Diabetes mellitus, here in galactosemia there is excretion of galactose in urine, that will give the Benedict test positive, but when you estimate the blood glucose level, it will be normal because the glucose oxidase peroxidase method detect only beta D glucose, not galactose. So here the Benedict test will be positive in the urine, but the GOD POD test on the blood means it will give the normal glucose value. Got it? Or it will give the low glucose value because of hypoglycemia if patient is in the fasting condition. Okay, then diabetes mellitus, diabetic ketoacidosis, these are the important cases. Okay. Now coming to the lipid chemistry and lipid metabolism, the important case is respiratory distress syndrome, which is particularly due to the deficiency of surfactant, that is dipalmityl lecithin. Dipalmityl lecithin, also known as dipalmityl phosphatidyl choline. Okay, so it is particularly in the premature baby because synthesis of the lecithin occurs after 34 weeks of the gestation. So particularly affect the premature baby, causes the symptoms, that is rapid breathing, grunting sound, cyanosis, means bluish coloration of nails, fingers, lips, then chest retraction, flaring of the alanizi, and amniotic fluid LS ratio, if it is less than 1, it indicates the immaturity of the lung. If it is more than 2, it indicates the mature lung. Okay, LS ratio, lecithin sphingomyelin ratio, and X-ray changes are there in the respiratory distress syndrome. So it is due to the defective deficiency of the surfactant, that is dipalmityl lecithin. Then the fatty acid oxidation disorders, that includes the SIDS, sudden infant death syndrome. It is 10% cases of sudden infant death syndrome are thought to be caused due to the medium chain acyl CoA dehydrogenase deficiency. It is due to the acyl CoA dehydrogenase deficiency. Because of the beta oxidation, there is defect in the beta oxidation, death occurs in the night. Death of the child occurs, unexpected death of the child occurs in the night if if he is on the fasting, if the fasting is more than 12 hours because of blockade of the beta oxidation. As the ATP required for the gluconeogenesis, they are provided by the beta oxidation. So if there is blockade in the beta oxidation, sudden death of the infant occur, that is known as sudden infant death syndrome because of defect in the acyl CoA dehydrogenase enzyme. Then second is the Jamaican vomiting sickness, which is due to the vomiting. There is excessive or severe vomiting due to the consumption of unripe ackee fruit. It is particularly seen in the Jamaica of Africa. This unripe ackee fruit contain hypoglycin A. This is a toxin which inhibit the acyl CoA dehydrogenase enzyme. Inhibit acyl coenzyme A dehydrogenase enzyme and block the beta oxidation. Blocks the beta oxidation. So there is vomiting in Jamaican vomiting sickness. Repsom's disease, now it is included in the Zellweger spectrum disorder. It is a peroxisomal biogenesis disorder. It is thought to be due to the alpha oxidation defect in the alpha oxidation. The symptoms are neurological manifestations, ataxia and retinitis pigmentosa. It is due to the defect in the enzyme phytanic acid oxidase, and due to the defect in the phytanic acid oxidase, the branch chain fatty acid, that is phytanic acid, get accumulated and it causes the symptom. Phytanic acid get accumulated and it causes the symptom, that is the Repsom's disease. Zellweger syndrome, it is also known as cerebrohepatorenal disease. It is a peroxisomal biogenesis disorder in which the proteins are not targeted to the peroxisomes. So proteins are not targeted to the peroxisomes. That's why there is empty peroxisomes, or peroxisomal ghosts are there. So because of lack of peroxisome or lack of functional peroxisome, the oxidation of very long chain fatty acid is affected and it get accumulated in the various tissue, particularly in the brain, kidneys and liver, and it causes the symptoms, that is Zellweger syndrome. So it is particularly important for MCQ, Zellweger syndrome. So these are the disorders. कौन कौन से डिसऑर्डर है यहाँ पे? रेस्पिरेटरी डिस्ट्रेस सिंड्रोम, सडन इन्फेंट डेथ syndrome, Jamaican vomiting sickness, Repsom's disease, and Zellweger syndrome. Now, the important one and the trending topic now, that is hyperlipoproteinemia, the Fredrickson classification of hyperlipoproteinemia. Remember, for UG student, the type 1A, so type 1 and type 2A, these two are very, very important. Forget about the rest. Type 1 and type 2A. Type 1 is due to the lipoprotein lipase defect or ApoC2 defect. Okay, type 1, and it is a type 1, it is familial chylomicronemia, hyperchylomicronemia. So this is a disorder, type 1 hyperlipoproteinemia or hyperchylomicronemia. In this type 1 disorder, there is increase in the chylomicron. As all of you know that chylomicron carries the VLDL. Chylomicron carries the TG, triacylglycerol. So TG levels are raised, chylomicron levels are raised. The appearance of the plasma is milky plasma appearance. This is type 1 hyperlipoproteinemia. As there is increase in the triglyceride level, patients are more prone for the pancreatitis. Then second, if there is increase in the cholesterol level, there is tendon xanthoma, and it is a type 2, that is LDL receptor or ApoB100 defect. Type 2, that is also type 2 hyperlipoproteinemia, also known as familial hypercholesterolemia. So there is increase in the cholesterol level, and the patients are more prone for the coronary artery diseases and atherosclerosis. यहाँ पे कोलेस्ट्रॉल इंक्रीज होता है, यहाँ पे काइलोमाइक्रॉन इंक्रीज होता है. कोलेस्ट्रॉल इंक्रीज होता है तो टेंडन xanthoma होता है, और ट्राइग्लिसराइड अगर बढ़ा हुआ है तो इरप्टिव xanthomas होते हैं. इरप्टिव xanthomas. ओके, सो इरप्टिव xanthomas आर देयर इन द टाइप 1, 4 एंड 5 एंड दे आर मोर प्रोन फॉर द पैनक्रेटाइटिस. मैंने कितने याद रखने को बोला आपको? टाइप 1 and type 2A. Type 1 is due to the lipoprotein lipase deficiency or ApoC2 defect. There is increase in the chylomicron level. There is milky plasma appearance, and as the chylomicron levels are raised, TG levels are also raised in the type 1 hyperlipoproteinemia. Type 2A is the LDL receptor defect or ApoB100 defect. In this, there is tendon xanthoma, there is increase in the cholesterol level, and they are more prone for the coronary artery diseases and atherosclerosis. So hyperlipoproteinemia. Then in hypolipoproteinemia, a beta means no beta lipoprotein synthesis is there. A beta lipoproteinemia. Because of no beta, there is no chylomicron, no LDL and no VLDL. Only HDL is there. HDL is normal. All other beta lipoproteins, they are abnormal or absent. Okay, and familial alpha lipoprotein deficiency, the Tanger's disease is important. There is low or absent HDL level. The orange colored tonsil, it is a feature of the Tanger's disease. This is a MCQ, important MCQ. It is due to the transport protein defect, that is ABCA1 defect. Okay, ABCA1, this transport protein is mutated or defective. It is characterized by familial alpha lipoprotein deficiency. Okay, so this is 27. The 28, fatty liver, this is important. The clinical features are pain in the right side of the abdomen, nausea, non-specific symptoms are there, nausea, loss of appetite, weight loss, jaundice and weakness. Lab investigation will show increased TG level, increased cholesterol level, and UCG, USG and biopsy, they are diagnostic. So USG and biopsy, they are diagnostic. There may be a history of alcohol consumption, chronic alcohol consumption, and increase in the TG level. Increase in the TG. The chronic alcohol consumption, see, the ethanol is converted into acetaldehyde. Acetaldehyde is converted into acetic acid. During this conversion, there is increase in the NADH level, and this NADH causes the shift of this oxaloacetate to malate. So there is decreased level of oxaloacetate. Because of excessive alcohol or chronic alcohol consumption, there is decreased level of oxaloacetate, and oxaloacetate is important for the burning of acetyl coenzyme A. As oxaloacetate is not there, it is not diverted. Acetyl coenzyme is not diverted for the TCA cycle. It will undergo the fatty acid synthesis and triacyl glycerol synthesis. So there is increase in the level of triacyl glycerol, and deposition of triacyl glycerol in the liver tissues, liver cells, causes the fatty liver. The lipotropic factors are there which can prevent the fatty liver. That includes the choline, betaine, inositol, B12, etc. Okay, so this is about the fatty liver. Now coming to the important lipid storage disorder, which is a important for the PG entrance examination, and also this Gaucher's disease, it is also important for the first MBBS student. In Gaucher's disease, there is defective enzyme is beta glucocerebrosidase. If there is defect in the beta glucocerebrosidase, there is accumulation of beta or glucocerebroside. There is accumulation of cerebroside in the liver, spleen, and bone marrow. As it involves the liver and spleen, there is hepatosplenomegaly, and as it involves the bone marrow, there is anemia, leukopenia, and thrombocytopenia. And because of thrombocytopenia, bruising disorder is there, means bleeding disorder is there. And apart from this, there is avascular necrosis of the bone, and also changes in the long bone, that is flask shaped deformity in the long bone, that is known as Erlenmeyer deformity in the long bone, which is seen on the X-ray. And this is a classical feature, that is Gaucher cell, that is intracytoplasmic inclusion body. The lipid laden macrophages are there. The macrophages are loaded with the lipids, that is glucocerebroside, and that gives the typical appearance, that is wrinkled paper or tissue paper appearance. This is the important point for the MCQ. That gives the wrinkled paper or tissue paper appearance of the macrophages. Okay, so this is about the Gaucher. It is a most common lipid storage disorder. Now the Niemann-Pick disease, it is due to the defect in the sphingomyelinase. There is accumulation of sphingomyelin, specifically in the nervous tissue, and that causes the CNS manifestation and hepatosplenomegaly. And there is cherry red spot on the macula. There is cherry red spot on the macula. In all lysosomal storage disorder, there is cherry red spot on the macula except KGF, that is Krabbe's disease, except KGF, Krabbe's Gaucher's, and KGF, Fabry's disease, except KGF, Krabbe's disease, Gaucher's disease, and Fabry's disease. All other disorder, there is cherry red spot on the macula. So hepatosplenomegaly is there, and cherry red spot on the macula, and CNS manifestations in there because of accumulation of sphingomyelin in the Niemann-Pick disease. Then the Tay-Sachs disease, it is a GM2 gangliosidosis. There is accumulation of GM2. Okay, GM2 gangliosides. There is no organ involvement in the Tay-Sachs disease. Hepatosplenomegaly is not there. There is intellectual disability and brain is involved, and cherry red spot on the macula. These are the features of the Tay-Sachs disease. So remember just Gaucher's disease, Niemann-Pick, and Tay-Sachs. All other diseases are there. Fabry's disease, Farber's disease, metachromatic leukodystrophy is there. So Krabbe's disease is also there. Number of disorders are there. Now coming to the proteins, discussion of the protein, the multiple myeloma. It is a plasma cell tumor characterized by multiple punched out lesion on the bone. Plasma cell carcinoma characterized by multiple punched out lesion on the bone. It is a monoclonal gammopathy in which particularly one type of immunoglobulins are produced, and it gives the typical M band on electrophoresis. M band on electrophoresis. Monoclonal gammopathy, only one type of immunoglobulins are produced, and that gives a band or sharp band in electrophoresis, that is known as M band in electrophoresis. And it is also characterized by excretion of the light chain proteins, that is Benz Jones proteins in the urine, which are detected by the classical HIT test. classical heat test. They have property to coagulate at particular temperature, and also if you go on increasing the temperature, the coagulum will disappear. So this is a these are detected by the heat coagulation test or classical heat test, Benzone protein excretion in the urine. This is multiple myeloma. Okay. Now the urea cycle disorder, there are 5 disorders in the urea cycle disorder. If there is, when you go for or think for the urea cycle disorder, whenever there is hyperammonemia, means ammonia levels are raised, and the CNS manifestations are there, because ammonia depletes the alpha ketoglutarate level and hampers the ATP production. So whenever there is increase in the ammonia level, you can think about the urea cycle disorder, and also it gives the CNS manifestations in the form of blurring of vision and slurring of speech. So these are the disorder: hyperammonemia type 1, hyperammonemia type 2, citrullinemia, arginosuccinic aciduria, and argininemia. These are the 5 urea cycle disorders in which there is increase in the NH3 level. If there is, along with the NH3, there is increase in the orotic acid, it indicates the hyperammonemia type 2. It indicates the hyperammonemia type 2. If there is increase in the citrulline, it indicates the citrullinemia. If there is increase in the arginosuccinic acid, it is arginosuccinic aciduria. And if there is increase in the arginine level along with the ammonia level, it indicates the hyperargininemia. So if there is increase in the ammonia level and the CNS manifestations are there, think about the urea cycle disorder. One syndrome is related with this urea cycle disorder, that is triple H syndrome, that is hyperammonemia, hyperornithinemia, and homocitrullinuria. These are the triple H: hyperammonemia, hyperornithinemia, and homocitrullinuria. This is due to the mutation in ORNT1 gene, ornithine transporter gene, because of which ornithine cannot be transported from cytosol to the mitochondria. So that's why there is syndrome that is known as triple H syndrome. So these are the urea cycle disorders. Okay. Now coming to the individual amino acid metabolism and disorders related with them, most common is the phenylketonuria, mousy order of urine. Then alkaptonuria, urine turns dark on standing. थोड़ी देर के लिए रख दिया तो काला black color का हो जाएगा, that is alkaptonuria. Then albinism, the generalized hypopigmentation is there in the albinism, and carcinoid syndrome. We'll discuss that. So these are related with the phenylalanine and tyrosine metabolism, that is PKU, alkaptonuria, and albinism. In phenylketonuria, there is mousy odor of urine. Screening test is the Guthrie test, and the tandem mass spectrometry is the diagnostic test for the phenylketonuria. The CNS manifestations are there because of there is increased phenylalanine level, which is diverted for the production of other byproduct. That will particularly there is decrease in the dopamine, norepinephrine, and epinephrine level. Also, it affects the tryptophan metabolism. So CNS manifestations are there, and as it affect the tyrosinase activity, hypopigmentation is there. So phenylalanine is restricted in the diet, and tyrosine is given. So there is blockade in the reaction, that is phenylalanine to tyrosine conversion. Because of deficiency of phenylalanine hydroxylase enzyme. Defect in phenylalanine hydroxylase enzyme. So this phenylalanine is diverted for the other byproduct. For example, it will give the phenyl phenyl acetate, which gives the mousy odor to the urine. Phenyl acetate, phenyl lactate, phenyl acetyl glutamine, phenyl pyruvate is the ketone body. The phenyl pyruvate is the ketone body. That's why it's known as phenyl ketone urea. Okay. Now alkaptonuria usually asymptomatic autosomal recessive condition. Adult तक उसको पता नहीं चलता कि अल्कैप्टोन्यूरिया है, क्योंकि जो यूरिन डार्क होता है उसको टाइम लगता थोड़ा सा, तो वो अननोटिस चला जाता. Okay, if the diaper stains black, it can diagnose the alkaptonuria. On standing, after some time, urine turns into the dark on exposure to the air, specifically due to the formation of alkaptone. Okay, so alkaptonuria, it is due to the defect in the enzyme homogentisate oxidase, due to which homogentisate levels are raised, homogentisic acid levels are raised, and it has strong reducing properties. So there is positive ferric chloride and positive silver nitrate test. Okay, so it has tendency to develop arthritis in the adult because of deposition of alkaptone. Alkaptone get deposited in the skin, cartilage, sclera, and that gives the black color to this. Why there is formation of alkaptone? Because the homogentisate is diverted for the production of benzoquinone acetate, and on polymerization this benzoquinone acetate is converted into alkaptone, which causes the ochronosis, means blackish deposition, ochronosis. This is alkaptonuria. Albinism, it is due to the defect in the enzyme tyrosinase, and the generalized hypopigmentation is there, and person is sensitive to sunlight, and there is photophobia. So phenylketonuria, it is due to phenylalanine hydroxylase defect. Alkaptonuria, it is due to homogentisate oxidase defect. Albinism, it is due to the defect in the tyrosinase. Carcinoid syndrome, it is related with the tryptophan metabolism. It is a tumor of argentapin cell of the intestine. इसमें क्या होता है, द tryptophan is converted into serotonin. More tryptophan, near about 60, more than 60% of tryptophan is converted into serotonin, and increase in the serotonin will give these symptoms: skin flushing, facial skin lesion, diarrhea, rapid breathing, and heart rate. These are the symptoms due to increased serotonin level. More than 60% of the tryptophan is converted into serotonin, and because of serotonin, these are the symptoms. This is a carcinoma of argentapin cell of the intestine. Okay, carcinoid tumor. Okay, so phenylketonuria, phenylalanine hydroxylase defect; alkaptonuria, homogentisate oxidase defect; albinism, tyrosinase defect; and carcinoid syndrome, tryptophan metabolism, defect in the tryptophan metabolism. Next one is the primary hyperoxaluria. It is related with the glycine metabolism, in which this is related with the glycine metabolism. There is defective targeting of the glycine transaminase. This enzyme is involved in the conversion of glyoxylate to glycine. It is involved in the conversion of glyoxylate to glycine. In absence of this glycine transaminase, this glyoxylate is converted into oxalate, and there is tendency of oxalate stones. This is related with the glycine metabolism, primary hyperoxaluria. Then homocysteinuria, it is related with the methionine and cysteine metabolism. In homocysteinuria, there is elevated homocysteine level in blood, and it is excreted in the urine. As it is characterized by ectopia lentis, means subluxation of the lens, long bones, tall stature, and Marfan syndrome like features are there. Serious abnormality because of raised homocysteine level. It interferes with the collagen cross-link, and it causes the reactive oxygen species formation, which favors the formation of oxidized LDL, and it causes the serious abnormality. It homocysteine level interferes with the collagen. It leads to the reactive oxygen species formation, and that causes the oxidized LDL formation, and oxidized LDL formation causes the atherosclerosis and serious abnormality. There is cyanide nitroprusside test which is positive for the homocysteine level. So homocysteinuria, cyanide nitroprusside test is positive. There is increased homocysteine level, increased methionine level because homocysteine is converted into methionine, and there is decreased cysteine level because homocysteinuria, it is due to the defect that is known as cystathionine beta synthase. Cystathionine beta synthase defect. So this is, see, this is methionine. It is converted into S-adenosyl methionine. S-adenosyl methionine is converted to S-adenosyl homocysteine, which is converted into homocysteine, and homocysteine is converted into methionine. And this homocysteine condenses with the serine and converted into cystathionine. And cystathionine is converted into cysteine. So here is the block. There is increased homocysteine level, increased methionine level, but the cysteine level decreases. So cysteine has to be supplemented in the diet in the treatment of homocysteinuria, while restrict the homocysteine and methionine level. So this is homocysteinuria. Ectopia lentis and Marfan syndrome like feature, tall stature, organodactyly. These are the features of homocysteinuria. Then in cysteinuria, there is excretion of cysteine, ornithine, cola, COLA, cysteine, ornithine, lysine, and arginine in the urine because of defective absorption of this amino acid in the renal tubule, and it has tendency to form the renal stones. This is cysteinuria. Okay. So primary hyperoxaluria, glycine metabolism defect, that is defective targeting of the glycine transaminase, homocystinuria, cystathionine beta synthase, and cystinuria, it is defective absorption of the cola, cysteine, ornithine, lysine, arginine. Then maple syrup urine disorder, it is related with the metabolism of valine, leucine, and isoleucine branch chain amino acid. There is typical smell, that is burnt sugar, smell of maple syrup or burnt sugar of the urine. There is neurological manifestation. This disease has progressive intellectual disability and neurological manifestations because of accumulation of these branch chain amino acid and their respective keto acid. So ketoacidosis is there. So there is increased excretion of valine, leucine, isoleucine and their keto acids, which gives their increased accumulation in the certain tissues causes the damage, for example, brain. Okay, and also there is positive Rothras test and also positive DNPS test because of increased keto acid in the urine. It has neurological manifestation and typical smell is smell of burnt sugar, maple syrup urine disease, valine, leucine and isoleucine metabolism because of defect in the enzyme. So this valine, leucine and isoleucine, these are the amino acids. They are converted into their alpha keto acids. Amino acids are converted into alpha keto acid by the transamination reaction, transaminase, and this alpha keto acids by alpha keto acid dehydrogenase, it is converted into acyl coenzyme A. So defect in this alpha keto acid dehydrogenase causes the maple syrup urine disease. Okay, branch chain alpha keto acid dehydrogenase. The name is branch chain alpha keto acid dehydrogenase. So maple syrup urine disease. Now coming to the nucleotide metabolism, three important disorders in the nucleotide metabolism, that is gout, Lesch-Nyhan syndrome and orotic aciduria. Gout, all of you know the gout, that is involve the first metatarsophalangeal joint. There is deposition of uric acid or monosodium urate in the synovial fluid of the joint and that leads to the tophus formation. It particularly involved the great toe, that is known as podagra gout. It involves the great toe. First metatarsophalangeal joint is the most common joint involved in the gout, followed by the ankle joint, knee joint, wrist joint, etc. Okay, laboratory diagnosis is by aspiration of synovial fluid and microscopy, in which you will get negative birefringent crystals, monosodium urate crystals in the joint deposition. So this is the diagnostic test. There is increased uric acid level in the gout and treatment is allopurinol, which is competitive as well as the suicide inhibitor of the xanthine oxidase enzyme. So allopurinol is given in the treatment. There are primary gout and secondary gout. The causes of primary gout mainly includes the increased activity of PRPP synthetase, increased activity of glutamyl amidinotransferase, increased activity of glutathione reductase, and decreased activity of HGPRTase and decreased activity of glucose 6 phosphatase, that is, it is linked with the von Gerg's disease. So these are the causes of primary gout. Gout, first metatarsophalangeal joint, synovial fluid aspiration and microscopy, and the monosodium urate crystals. It is diagnostic or gold standard test for the diagnosis of the gout. This is given in the treatment, competitive as well as suicide inhibitor of the xanthine oxidase enzyme. Then Lesch-Nyhan syndrome, टिपिकल बिहेवियर, सेल्फ म्यूटिलेटिंग एक्टिविटी, नाखून खाना है ना, खून निकलने तक नाखून खाना, दैट इज सेल्फ म्यूटिलेटिंग एक्टिविटी, एग्रेसिव बिहेवियर, मेंटल रिटार्डेशन. दिस इज एक्स लिंक्ड डिसीज, typically affect the males. Then orotic aciduria, it is due to the defect in the enzyme. O2 defect means OP-ARTase, orotate, OP-ARTase, orotate phosphoribosyl transferase, and OMP decarboxylase. These are the two enzymes defective in the orotic aciduria. The symptoms are failure to thrive, inability to gain weight. Megaloblastic anemia is the feature of the orotic aciduria. There is excretion of orotate in urine. ये point यहाँ पे रहेगा ही, excretion of orotate in the urine. ओरोटेट दो जगह पे एक्सक्रीट होता है, पहला तो ओरोटिक एसिडूरिया और दूसरा यूरिया साइकिल डिसऑर्डर टाइप 2, दैट इज ऑर्निथिन ट्रांसकार्बोमाइलेज डिफेक्ट. ये दो याद रखना है. This is a cause of megaloblastic anemia as it is involved in the thymidylate synthesis. So orotic aciduria is due to OP-ARTase defect and OMP decarboxylase defect. Lesch-Nyhan syndrome, it is HGPRTase, hypoxanthine guanine phosphoribosyl transferase defect, and it is related with purine salvage pathway. Purine salvage pathway. This is important pathway for the brain. The synthesis of nucleotide in brain and RBCs typically dependent on the purine salvage pathway, in which the guanine and hypoxanthine, they are converted into their corresponding nucleotide. So as there is defective HGPRTase, there is decreased synthesis of nucleotide in the brain. So that's why the neurological manifestations are there. And gout, there are primary gout, secondary gout. Okay. Now coming to the hemoglobin chemistry and metabolism disorder, main is the sickle cell anemia. There is pain in the extremities, anemia, pallor. So pain in the extremities, pallor, fatigue, frequent infection. This is because of blockade of the capillaries and decreased blood supply to the part distal to that capillary. Okay, because of sickling of the RBC, this is the molecular defect in which glutamate is replaced by the valine. So it carries less negative charge as compared to glutamic acid, and slow move on electrophoresis. So it will slowly move on in the electrophoresis and give the single band of hemoglobin S. So why there is sickling occur? Because of the molecular defect in which glutamate is replaced by the valine. Because of the molecular defect, there is sticky patch on the deoxyhemoglobin S, and the receiver is also there. So polymerization of deoxyhemoglobin S causes the formation of fiber that distort the shape of RBC into sickled shape. So and sickled shape will block the capillaries and decreases the blood supply to the part. So there is pain in the extremities. This is a typical feature along with the anemia. Okay, so it is diagnosed on the electrophoresis, sickle cell anemia. Okay, thalassemia, particularly the beta thalassemia major, the homozygous trait in which there is few or no beta chains are there. So there is decrease in the hemoglobin A or absent hemoglobin A. Beta thalassemia major homozygous state. So there is no beta chain, so decrease in the hemoglobin A, while hemoglobin F and hemoglobin A2 there is increased synthesis. So there is anemia, jaundice, hepatosplenomegaly. There is facial appearance, thalassemic facies, that is frontal bossing and the maxillary overgrowth. This gives the thalassemic facies because of the hematopoiesis in this bone. So there is hepatosplenomegaly, there is jaundice and the facial appearance, that is typical facial appearance, and X-ray will give hair on end appearance of the skull. So this is the thalassemia major. There is anemia, there is decrease in the hemoglobin A, there is increase in the hemoglobin F and hemoglobin A2, anemia, jaundice, hematopoiesis in the bones that causes the abnormal bones, that is frontal bossing and maxillary overgrowth is there. So these are the features of the thalassemia. This is a quantitative defect, decrease in the beta chains, decrease in the beta chains. Then the porphyrias, in which porphyrins are excreted in the urine. So acute intermittent porphyria, porphyria cutanea tarda, and congenital erythropoietic porphyria, these are the important one. All porphyrias are dominant except congenital erythropoietic porphyria. In acute intermittent porphyria, there is abdominal pain and neuropsychiatric manifestations. These are the two important symptoms. There is increased level up. This is acute intermittent porphyria. It is due to uroporphyrinogen 1 synthase defect. Uroporphyrinogen 1 synthase, UPG1 synthase defect, and due to which there is excretion of aminolevulinic acid and porphobilinogen in the urine. Another name is porphobilinogen deaminase. Porphobilinogen deaminase. Okay. So there is abdominal pain and neuropsychiatric manifestation. These symptoms, intermittent abdominal pain. So acute intermittent porphyria due to the uroporphyrinogen 1 synthase defect, increased excretion of ALA and porphobilinogen in the urine. Porphyria cutanea tarda, there is only photosensitivity or skin lesions are there because of the porphyrins. Porphyrins are excited at the nanometer 400 nanometer, and porphyrins are lead to the synthesis of reactive oxygen species which causes damage to the lysosomes. And as lysosomes are damaged, this causes the release of enzymes which degrade the skin, which causes the skin lesions. Okay, so excited porphyrins, they causes the reactive oxygen species generation. and that damage the lysosomes, that releases enzyme, and that causes the skin lesion. So photosensitivity is there in the Porphyria cutanea tarda. It is due to the defect in the enzyme uroporphyrinogen decarboxylase. Decarboxylase. Uroporphyrinogen decarboxylase. Congenital erythropoietic porphyria, it is a autosomal recessive disorder due to the uroporphyrinogen 3 co-synthase defect. Uroporphyrinogen 3 co-synthase defect, and there is photosensitivity, there is scarring, repeated scarring, and skin lesion gives the facial appearance like werewolves. So ugly skin, facial lesions are there. There is excretion of red urine, and wood lamp examination of teeth shows the fluorescent teeth. So fluorescent teeth are there, red urine, and the scarring, repeated scarring, that gives the ugly look, and the facial hairs are also there. So that is congenital erythropoietic porphyria due to the defect in uroporphyrinogen 3 co-synthase. So sickle cell anemia, pain in the extremities, anemia, pallor, the crisis may be there because of sickling of the RBCs. Thalassemia, quantitative defect of the beta chain, decreased beta chain synthesis causes the manifestation. Acute intermittent porphyria, abdominal pain and neuropsychiatric manifestation. Porphyria cutanea tarda, the bullous skin lesions are there. Congenital erythropoietic porphyria, photosensitivity, and the blistering skin lesions are there, red urine and fluorescent teeth on examination. Okay. Now the case number 50, that is neonatal physiological jaundice. The jaundice or yellowish discoloration, particularly 2 to 3 days after the birth in premature babies because of immature hepatic system to conjugate the bilirubin. So immature hepatocytes are there, and because of this unconjugated bilirubin levels are raised. So there is increase in the indirect bilirubin level, and phototherapy is given in the treatment. The light, blue light, particularly blue light, that is 420 to 470 nanometer light, causes the conversion of bilirubin into its excretable metabolite, particularly the lumirubin, and it is excreted in the urine. So the bilirubin level will drop day by day, bilirubin level will decreases. So if bilirubin levels are more, and if it goes or crosses the blood-brain barrier, as it is a uncoupler, it causes the CNS manifestations, that is known as kernicterus. That is known as kernicterus. There are also congenital disorders which is related with the bilirubin. That is, if there is increase in the direct bilirubin, the congenital causes includes the Rotor syndrome and Dubin-Johnson syndrome. Rotor syndrome and Dubin-Johnson syndrome. And indirect bilirubin, raised indirect or unconjugated bilirubin, the causes are Crigler-Najjar type 1 and type 2, Crigler-Najjar type 1 and type 2, and Gilbert syndrome. Gilbert syndrome. If there is jaundice on the first day after the birth, it indicates the RH and ABO incompatibility. RH and in ABO incompatibility. Jaundice after the birth, first day of the birth, within 24 hours of the birth, that indicates RH incompatibility or ABO incompatibility. Here the yellow skin after 2 to 3 days after the birth, that indicates the neonatal physiological jaundice because of immature hepatic system to conjugate the bilirubin. Okay, and these are the congenital causes of direct and indirect bilirubin level. Congenital causes of increased bilirubin. If there is direct bilirubin raise, it can be due to Rotor or Dubin-Johnson syndrome. If there is indirect raise, that is Crigler-Najjar type 1, type 2, or the Gilbert syndrome. In Crigler-Najjar type 1, the bilirubin may go beyond 20. It causes the kernicterus. Type 2, it is a partial deficiency. It may be up to 14 or less severe than the Crigler-Najjar type 1. In Gilbert, it is up to 4 milligram per deciliter. So these are the different cases from the different topic, that is the metabolism, enzyme, carbohydrate, protein, lipid metabolism, hemoglobin metabolism, and nucleotide metabolism. Okay, so this is all about the clinical cases from this topic. So keep watching. Thank you.